Hi, I am Shurouq Khalifa. I will talk about antepartum hemorrhage. Antepartum hemorrhage is defined as bleeding from the genital tract during the second half pregnancy. Ante- Antepartum hemorrhage is one of the top causes of maternal death. Antepartum hemorrhage is one of the vaginal bleeding after 24 weeks of gestation could be due to different causes. Around 50% of antepartum hemorrhage is due to placental causes. Other sources of bleeding are from the fetus, uterus, cervix, vagina, or due to bleeding disorders. Placental abruption and placenta previa are the most common causes of antepartum hemorrhage from the placenta. Placental abruption is a premature separation of normally implanted placenta prior to delivery of the fetus. It accounts for 30% of antepartum hemorrhage. It's characterized by a painful vaginal bleeding. The pathophysiology of placental abruption is believed due to weakness of the spiral arterioles. This weakness leads to bleeding between the uterus and the placenta. This will form a hematoma. This hematoma will lead to separation of the placenta from the uterus. The more the bleeding, the more the hematoma. The larger the hematoma, the more the separation and the more decrease of oxygen supply to the fetus and more maternal blood loss. This will cause hypertonic uterus. The uterus will contract to prevent more bleeding. The most important risk factors of placental abruption are previous history of placental abruption and maternal hypertension. Other factors include trauma, rupture of the membrane, rapid decompression with a polyhydramnios patient, short umbilical cord, tobacco use, folate deficiency. 80% of the patient will present with vaginal bleeding. 70% of them will have uterine tenderness. Uterine tenderness is due to escape of the blood to the myometrium of the uterus, which will cause covulate uterus. In 35%, they will have uterine contractions or uterine hypertonus. Because of the decreased oxygen supply to the fetus, it's very common to find fetal distress with placental abruption. Unfortunately, in 15% of the patient will present with intrauterine fetal death. It's very important to know that bleeding from placental abruption could be revealed and can be seen through the vagina and could be concealed, that the hematoma will be inside the uterus and no blood loss will be appreciated on examination. It's very important to know that bleeding from placental abruption could be revealed and can be seen through the vagina and could be concealed, that the hematoma will be inside. Diagnosis of placental abruption is always clinical. Ultrasound is usually done to rule out placenta previa, but can be discovered in 2% of the cases. Postpartum evaluation of the placenta will show some signs of placental abruption. Placental abruption carry a high perinatal mortality rate, and because of hypoxia, 15% of living cases are with severe neurologic impairment. 15% of third trimester stillbirth are due to placental abruption. Mothers with placental abruption, they will have a bleeding, may develop hypovolemic shock. They are at high risk of having defect in coagulation. Because of the blood loss, They are also at risk of acute renal failure, Sheehan syndrome, and death. The second most common of antepartum hemorrhage from the placenta is placenta previa. Placenta previa is a condition where the placenta lies low in the uterus and partially or completely covers the cervix. It accounts for 20% of all antepartum hemorrhage. It causes painless vaginal bleeding. Risk factors of placenta previa include the following: multiparity, increased maternal age, previous history of placenta previa, multiple gestation, prior uterine surgery such as cesarean section or myomectomy. Placenta previa is classified according to the internal cervical os. It could be minor or major. Minor placenta previa could be low-lying when it's 2.5 cm away from the internal cervical os, or marginal when it ends just at the beginning of the internal cervical os, or could be major when the placenta covers the internal os. This coverage could be partial or complete. Placenta previa is diagnosed by ultrasound. But remember, any patient will present with antepartum hemorrhage. Never to do PV examination before doing ultrasound and confirming the placental site. PV examination in cases of placental previa will initiate or increase the vaginal bleeding and can lead to severe hemorrhage. Placenta previa increase the risk of preterm delivery, either because the vaginal bleeding will irritate the uterus and stimulate uterine contraction, or because the mother is having heavy bleeding, which indicates termination of pregnancy and cesarean section. Malpresentation is associated in 30% of placenta previa. Placenta previa has a high maternal mortality rate. It's due to hemorrhage that happen either antepartum or intrapartum. It's important to know that there is difficulty in controlling bleeding from lower uterine segment. This is because it lacks the musculature of the myometrium that present in the upper part of the uterus, which contracts after delivery of the baby and the placenta and stop bleeding. Severe bleeding from placenta previa can lead to defective coagulation. Placenta previa is associated with placenta accreta, which is deep implantation of the placenta through the uterine layers, lead to difficulty in removal of the placenta. Other causes of antepartum hemorrhage is uterine rupture. It's a complete separation of uterine musculature through all layers. Despite it's uncommon, but still can happen. Patients on induction of labor or with uterine hyperstimulation or with prolonged labor with elements of failure to progress are at higher risk of uterine rupture. Previous cesarean section, especially the classical vertical cesarean section, increase the risk of uterine rupture. Patients with uterine rupture will suffer from hemorrhage, which can lead to shock. It's usually managed by hysterectomy. They are at higher risk of bowel and ureter injury. Uterine rupture carry a high perinatal mortality rate. 10% of survived babies will suffer from long-term neurologic sequelae. Bleeding in antepartum hemorrhage could be from the fetus. Fetal bleeding can happen because of rupture of fetal umbilical cord. It's very rare. It happens in 0.1 to 0.8% of all antepartum hemorrhage. Umbilical cord are at high risk of rupture in case of filamentous cord and vasa previa. Filamentous cord is the cord insert between amnion and chorion, while vasa previa is that the unprotected cord will pass over the cervical os. It's important to remember that bleeding in the second half of pregnancy could be a bloody show, which is a sign of labor. Other local causes of bleeding in the second half pregnancy could be from the cervix or from the vagina. Could be due to infection, ulcer, neoplasm, or injury in this area. Remember, in your initial assessment of patient with vaginal bleeding, not to perform a PV examination till placental localization is determined. Remember also that the amount of bleeding does not necessarily reflect the real amount of bleeding. Management of antepartum hemorrhage should be individualized according to the following: the cause of the bleeding, maternal condition, fetal condition, and gestational age. For more information, you can check my reference, Essentials of Obstetrics and Gynecology by Hacker and Moore, the 5th edition. Thank you for listening. For more information,